Hello, I'm Dr. Annalene Weston, dentolegal consultant at Dental Protection. Welcome to RiskBites, a series of podcasts created specifically for dental practitioners in Australia. RiskBites looks at the key dentolegal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. In this edition, I'm going to be talking with my colleague Helen Harbourne, who is Dental Protection's in-house lawyer, about a particular type of allegation that's being increasingly argued in compensation claims, and that's the allegation of assault, battery, and trespass. So we're going to have a look at what these terms mean in the eyes of the law and discuss how this might impact upon our members, and more importantly, how you can avoid being subject to such accusations. So Helen, I think it's probably good if we start by getting back to some basics, because I know when I think in the terms of assault or battery, I think of someone being physically or brutally assaulted. So in your terms then, in lawyers' terms, what exactly is classed as assault in the eyes of the law, and what's the difference between assault and battery?
Thanks, Annalene. And yes, most people would associate the term assault with a physical attack of some sort. So I imagine our members are wondering, what has assault got to do with the practice of dentistry? Well, the official legal definitions for assault and battery will vary slightly from state to state, but essentially assault in particular is very broad and will include any form of harm caused to another person, either physical or mental, and it can be direct or indirect, and which is occasioned without the person's consent. Importantly, there doesn't need to be the application of any force to be regarded as an assault. Rather, it merely involves creating in another person the apprehension of harmful or offensive contact. Battery, on the other hand, requires the actual contact to be made and usually involves some force, which is the slight difference between assault and battery.
Okay, so we might still be wondering then how this applies to the practice of dentistry. I mean, as long as our members don't go around hitting or threatening, how would it apply?
Unfortunately, no, it's not quite that simple, Annalene, though I would agree members should not go around hitting or threatening patients. I'm sure they don't. Given the very broad definitions discussed above, any treatment that is deemed to have been performed with a lack of informed consent or performance of any unnecessary dental treatment with no therapeutic purpose may be considered to be an assault and battery in the eyes of the law. Whilst battery must involve the physical force and contact, it's not hard for this to be established by a patient, given all dental treatment generally requires physical contact with the patient. Even a straightforward tooth extraction requires a reasonable level of force to be applied. In addition to this, in the healthcare setting, it is considered to constitute trespass to administer treatment of any kind to a patient without their informed consent. So trespass is another allegation that we tend to see in dental compensation claims.
Yeah, that's really interesting, Helen. So are you able to give us any examples of dental cases that have involved these types of allegations?
Yes, Annalene, the prominent Australian case is that of Dean and Fung, which has highlighted this very particular issue. In this case, the patient, Mr. Dean, attended upon Dr. Fung when he had suffered a workplace injury to his chin, which caused some minor damage to his front teeth. Over the course of the next 12 months, Dr. Fung carried out root canal therapy and fitted crowns on all of Mr. Dean's teeth. The treatment was undertaken over 53 consultations at a total cost of over $73,000 and was paid for by a third party as it arose from a workplace incident. Mr. Dean subsequently commenced proceedings against Dr. Fung for negligence and trespass, stating that the treatment was unnecessary and ineffective. As is apparent, he had a large amount of invasive dental work done by Dr. Fung. Although Mr. Dean had seemingly consented to the treatment, it was determined by the court to be because Dr. Fung had informed him that he needed the treatment, which was found to not be correct. In this case, it was determined that where the nature of the procedure has been misrepresented, consent will not be validly given. Further, if a legitimate issue is raised by a patient as to the existence of valid consent, the burden of proof will then shift from the patient and will then lie with the medical practitioner to establish that valid informed consent was undertaken. This case resulted in a judgment against the dentist in the sum of $1.7 million. That is a very high price to pay for undertaking some unnecessary treatment without proper informed consent.
Yeah, it is. And I remember this case and the shockwaves it sent through the profession at the time. And I always felt that the fact that the treatment was not deemed necessary cast a really unpleasant light on this matter. Now, of course, there have been other matters such as this, have there not, Helen?
There have, Annalene. Another similar Australian case is that of Johnston and Dr. Jasmine White. Ms. Johnston, aged in her 70s, attended Dr. White's dental surgery on numerous occasions over the course of 6 months for the purposes of receiving dental treatment, including filling her lower canine and molar teeth, which were affected by decay. During the course of these treatments, Dr. White also built up Miss Johnston's front bottom teeth. It was alleged that this caused her upper plate to crack because of the pressure from the overbuilt front bottom teeth. Miss Johnston commenced proceedings against Dr. White, not only alleging negligence, but also assault and trespass. In the first instance, the court found that the treatment carried out by Dr. White was wholly unnecessary, and further it was carried out for the sole purpose of making money. The judge found that there was no therapeutic purpose in performing the dental treatment, and further, that Dr. White had failed to establish that Miss Johnston had consented to the treatment. The court went so far to comment that essentially medical treatment provided without consent may not only constitute a wrongful act, but in some cases may even be considered criminal.
Yeah, that feels really harsh. I just want to pause for a moment just to say that these cases are going to be included in the episode notes if anyone wants to do any further reading. And also the cases that we're discussing are in the public domain. So what that means is that you can look them up. We're not telling people's secrets. And I think, Helen, it's really troubling to think that dental treatment provided daily, like fillings, could be regarded as a criminal act.
I completely agree, Annalene. It seems outlandish. However, in the eyes of the law and the courts, a practitioner undertaking treatment which has no potential therapeutic benefit to a patient is taken very seriously, as they are putting that patient at risk of significant injury and side effects for their own personal gain. That's the element that I think members most need to be mindful of. The courts in Australia consider that where a clinician is found to be solely motivated by a non-therapeutic purpose, the most common, of course, being financial gain, the patient's consent is considered to not be valid, and the treatment may therefore be considered to be an assault and battery.
Why do you think there's been an increase in the argument of assault and battery in recent times, Helen?
It's a good question, Annalene, and I do suspect that there are a couple of reasons. Firstly, I think the rise of advancements in dentistry is playing a role in this. Practitioners are possibly utilising new and innovative procedures that might, with the benefit of hindsight, not be adequately tested or peer reviewed.
Yeah, hindsight is generally a wonderful thing.
It is. Secondly, we are also seeing an increasingly higher demand for cosmetic procedures, which by their nature are undertaken predominantly for purely aesthetic purposes rather than a functional reason, thus opening up those practitioners to scrutiny, especially if they are treating red flag patients. The third area that we could see these allegations being made is where practitioners are performing treatment that is considered to be outside of their scope. In some instances, this in itself might be considered by a court to be reckless.
Now, thanks, Helen. But to be clear to our listeners, we're not in any way suggesting members have to undertake taking any of the procedures that Helen's just mentioned altogether.
No, that's certainly not the case. I just would strongly recommend that these practitioners just stop and consider the risk management that they have in place for managing these types of situations. In particular, patient selection and documentation of valid consent in writing is absolutely vital in these cases. For members that engage in the use of innovative appliances, particularly orthodontics, it's vital that they undertake due diligence before implementing treatment with these patients. They need to know what level of clinical trials and peer-reviewed studies the appliance or procedure has undergone and whether any studies have taken place in Australia or only overseas. If the courts consider it was not sufficient, then the use of that procedure or appliance is highly likely to be considered by the court to be reckless and or to have no therapeutic benefit and the treatment to be regarded as assault or battery.
Okay, so what then can members do to try and avoid having such allegations made against them?
Well, I think the two key learnings here, Annalene, that I hope all of our members will take from this are firstly, valid informed consent is not just something that's ideal. It's absolutely vital. For valid informed consent to be established, the patient must firstly have the legal capacity to consent. They must provide their consent voluntarily. They must provide consent for the specific treatment that is being discussed, and be provided with enough information about their condition, alternative treatment options, benefits and risks relevant to them to enable them to make an informed decision. This includes the opportunity to ask questions and discuss concerns. Further, and most importantly, in order to be able to prove that valid informed consent has been provided, it must be adequately documented. The other element I cannot stress enough is for members to ensure that all treatment must have some therapeutic value. Before recommending any additional treatment to a patient, stop and consider whether the proposed treatment is really necessary for that person and what therapeutic value does it hold for them. It is understood that dentists feel pressure to recommend additional procedures to their patients. This pressure may come from practice owners, from the patients themselves, or simply from the practitioner's own need to meet their financial commitments. However, as demonstrated from the case studies that we've talked about today, over-servicing often comes at a much higher cost than any profit you will receive from a patient. Dr. Fung received just over $73,000 for the treatment provided to Mr. Dean, but the ultimate cost to him was over $1.7 million.
And that's just the fiscal cost, of course. I'm sure there were several costs to Dr. Fung of this very public case. So that's great advice. Thank you, Helen. Have you got any parting words of advice for members on this issue?
Yes, Annalene, I would like to impress upon members that if your practice involves or has potential to be seen to potentially involve any of the treatments that we've discussed here today, it is vital that you give significant consideration to the following. Is the treatment directly within your scope of practice and experience? Is the treatment necessary and appropriate for that specific patient? Does the treatment hold therapeutic benefit for that specific patient? If the treatment is purely cosmetic or non-essential, is your consent process sufficiently detailed and recorded in writing? And does the patient have any signs of being a red flag patient? If the patient does show signs of being a red flag patient, you need to really consider whether it's worth treating them.
Thanks, Helen, and thank you all for listening. And we do hope that this podcast was helpful to you. And we look forward to sharing more guidance with you in the future. If you like Dental Protection podcasts and you'd like to hear more, please subscribe and leave a review.